This is oh wait, mic was on. 1 second. Hi Sparkles, welcome to the stream. How you guys doing? This is Jokeship, your Jokeship running retriever who can explode anything on touch. And today we are doing another study stream. We'll be finishing general medicine today. Hopefully, I don't know, I'm fine with it, so I think we can finish it really quickly. I did it multiple times before. And hi Clever, thank you for checking in first. And thank you for studying my first today. So yeah, I need to set up my webcam. It's gonna take a while. I'm trying to fix something. Why does it show League of Legends on? No, we're not playing League of Legends. No way. No League till tomorrow. There we go. Give me a second. I'm trying to fix something. So I'm trying to use my webcam app on my phone with Game Booster so that it bypasses the battery and doesn't overheat, but Game Booster is not showing up when I click on the app, and even if I put it on Gaming Hub, it just doesn't work. It just didn't show up. I don't know why. It doesn't recognize it as a game, of course, but I wish there was an option where we could do that. Yeah, I think another day of phone being overheated. Another day of phone being overheated. Second, guys, just a day of the week. Okay. Yeah, give me a minute. My stand is a bit broken. Okay. Oh, my phone is still open. Good. There we go. I didn't focus. Just focusing on my thighs. Oh shit. No, the entire stand fell off. It's a little messy. It'll take some time. Oh, my hand hurts. Really, I hate wires. I just pulled off my balls. Guys, give me a second and just fix this real quick. I need to adjust the camera. Okay. Shit, clean baby now. Okay, now I think now it's much better. Totally better. Black screen. Let's go. Where is the webcam? Okay, there we go. Let's start from the beginning. CBS. So we have about 100 pages. Should be done really quickly. Well, first the GIT. So a patient comes with jaundice, SGOT, SGPT elevated, has diabetes, pigmented skin. So pigmented skin or bronze skin, you think of hemochromatosis. Hemochromatosis investigations, you have to do iron studies, mainly transferrin saturation, HFE mutation. So screening is your iron studies, and confirmatory test is, of course, biopsy, C for gene mutation, HFE mutation. Biopsy is non-specific, my bad. Biopsy is non-specific. Confirmatory test is seeing the gene studies, genetic studies. Most common symptom is fatigue, hepatitis. Diagnosis, okay, we already said hemochromatosis. Treatment is by phlebotomy. So phlebotomy, you can have a reversible manifestation of hepatosplenomegaly, bronze skin. Wait, what? Okay. Jaundice, SGPT, SGOT elevated patient is a young female with recurrent hepatitis. So recurrent hepatitis, young female, often think of autoimmune hepatitis. So how do you confirm autoimmune hepatitis? You see for biopsy. Biopsy is confirmatory where you look for plasma cells, and ANA is screening test. ANA is just screening. It's not specific to autoimmune hepatitis. More specific antibody is LSA, and liver soluble antibody against liver soluble antigen. LKM1 is also seen in hepatitis C. Side effects. Right, so treatment is by steroids and azathioprine. Side effects is fatty liver due to steroids and portal hypertension due to azothioprine. Next, we have a patient with jaundice, SGPT, and SGOT elevated, second decade of life. Neuropsychiatry. What? KFAs. KFAs, of course, if they say KFA, it has to be Wilson's disease. So, what is the confirmatory for or gold standard for Wilson's disease is liver copper, and screening is serum cytoplasmin. You did not do a urine copper. You did liver copper. Urine copper is again screening. So other places where you can see KF rings is PBC and PSC. PSC it has to mention PI elevated. Now treatment of Wilson's disease is something with zinc and penicillamine. So antidote for copper, penicillamine, and zinc. Side effects, of course, they'll have nephrotic syndrome. Now, jaundice with SGPT and SGOT, again, the patient is diabetic, obese, but now we have acanthosis nigricans, so that means it has to be a metabolic disease. So, what we know is ANFLD or MASLD, metabolic dysfunction associated steatotic liver disease. So, treatment is by giving vitamin A, and there's a new drug in the market called resmetirom, which is a thyroid receptor beta agonist or acting on the liver. It causes increased fatty acid beta oxidation. Next, jaundice plus so next patient, the patient has jaundice, SGPT and SGOT elevated with frequent alcohol intake, neuropathy, and presence of acanthocytes. So this clearly knocking as alcoholic liver disease. We need to see the SGOT SGPT ratio. If it's more than 2, it is ALD. This is called as the Wrightis ratio, which is very specific investigation. So treatment is by steroids. If contraindicated, you give pentoxifylline, and if patient has a cirrhotic liver based on MEL score, you can do a liver transplantation. So there's something called Madri score for ALD. More than 32, you give steroids. Less than 32, you just do alcohol cessation. So Madri score is that equals 4.6 into plasma throughput P minus plasma throughput control patient minus plasma throughput control plus serum bilirubin. So 4.6 into plasma, so into PT patient minus PT control plus serum bilirubin. Now there are other scores as well. Let's first look into the score before going on to that. So we already said Madri score for ALD. Now Nassau score as well, Wilson's disease. You know what? Let's just write it down so that we don't keep missing it. Okay. So Nassau score is for Wilson disease, which indication for liver transplant, and if it's more than 9, you do a liver transplant. So easy. First, we start with Madri score, which takes into account, as we said, serum bilirubin and prothrombin of the patient and control. So now every score is based on this. Every score has bilirubin and prothrombin or INR. So now NASA score, you have an additional of SGOT. For MEL score is for a liver transplant. More than 18 is an indication for liver transplant, which is end-stage liver disease and cirrhotic liver. Again, here you do bilirubin, INR, and the additional one is creatinine here. Then we have there's MEL score. There's also PEL score. PEL score is for pediatric, and it's the same. It's the same. Even that's for liver transplant, just for a different reason. So next is Lilly score. Lilly score, very important. A steroid response in ALD less than 4.45. That means it's steroid responsive. Again, here you also take bilirubin and prothrombin, but here there's other factors like we call it A, B, C. H, albumin, B for bilirubin, C for creatinine, and PT for prothrombin. Next, we have child puke score based on cirrhosis severity, where class C is decompensated. Class A and B is compensated, and class C is decompensated. Here also we take bilirubin, prothrombin, but additionally we take albumin and like Lilly's ascites and encephalopathy. So, and let's go back. Yeah. Now we have a patient with ALP and GGT elevated. Now GGT is elevated, you might think of an obstruction like post-hepatic cause. So you look for CBD and USG, dilated or non-dilated. Non-dilated means there's an intrahepatic obstruction. Intrahepatic obstruction can mean a lot of things based on the age. If the patient is young, it could be a choledochal cyst, it could be an intrahepatic biliary atresia. Now, okay, choledochal cyst is extrahepatic. Intrahepatic could be a biliary atresia, it could be an intrahepatic biliary atresia. Or now the patient is older, it's a older patient. Now we've looked for AMA. AMA is positive or negative. AMA is positive, it's PBC. If AMA is negative and P ANCAT is positive, it's PSC. PBC is increased risk for hepatocellular carcinoma, whereas PSC is increased risk for cholangiocarcinoma. Now, if they give a case of PBC, they're gonna mention about AMA positive. They're gonna mention it's a female. They're gonna say she probably has Sjogren's syndrome. Whereas if it's PSC, they're gonna say it's a male with ulcerative colitis and PANCA positive, because PANCA is positive in both PSC and ulcerative colitis, and both are highly associated with each other. Now correlated with each other. Now viral hepatitis, mode of transmission is by fecal route by Hep A and Hep E. Most common of acute viral hepatitis in children relapsing is hepatitis A, and cholestatic hepatitis is hepatitis E. Hepatitis E also causes Bell's palsy and GBS. Bell's palsy and GBS, and both treatment is solely supported. There's no medications. Okay, now most common cause of viral hepatitis, most common cause of viral hepatitis causing hepatocellular carcinoma, and presence of serum sickness, joint pain, and rash is hepatitis B. which is most common viral hepatitis overall, and asymptomatic in acute phase, most common viral cirrhosis. Most common viral hepatitis in the case of cirrhosis is hepatitis C, which is fulminant liver disease. Next, we have max risk of fulminant hepatitis in hepatitis D, which is a superimposed infection on hepatitis B. The most common of fulminant hepatitis per se is parasitable toxicity. Most common cause of chronic hepatitis is hepatitis B, whereas the most common cause of chronic hepatitis is fulminant liver disease. Viral causes hepatitis B, but if you say most common cause per se, it's fulminant liver disease. Now we have serology of viral hepatitis. IgM anti-HIV positive, of course it has to be acute hepatitis A, and IgM is acute anti-HBC plus HBsAg positive. HBsAg positive means there's an active infection of hepatitis B. Now we have IgG positive, that's chronic anti-HBC, and HBsAg, that's chronic hepatitis B. Now we have HBV DNA high, that means there could be the HBV DNA means there's okay, they didn't mention anything about HBsAg, so maybe you can consider as negative and it's not active. But if HBV DNA is high, then there is hepatitis B somewhere. Now HBeAg is negative, that means it's a precore mutant. Now IgM is at acute, and HCV is acute hepatitis C. Now IgG is chronic hepatitis C. Now there are other stuff. Only HBsAg is positive, nothing else, then it's incubation period. Anti-HBs is positive and nothing else, it's vaccination. IgM anti-HBC is only IgM anti-HBC positive. There's HBsAg is negative, then there's no infection. It's in its window period. Now HBV DNA more than 2000, less than 2000, more than 2000. No biopsy, no need of doing biopsy. You have to start antivirus right from. If less than 2000 observation, you have to do a biopsy. So treatment for hepatitis C is sofosbuvir plus velpatasvir. Oh my god, these new drugs. Sofosbuvir and velpatasvir for 12 weeks. Now hepatitis B is lifelong, whereas hepatitis C you have to take for 12 weeks, which is 3 months. Sofosbuvir and velpatasvir. Now we already finished this. Ascites. So clinical signs, shifting dullness. We already talked about this yesterday. Minimum volume for shifting dullness is 500 ml, whereas fluid through minimum is 1500 ml. USG can detect up to from 100 ml onwards. Now, clinical signs are negative or positive. If it's negative, you just do a salt restricted diet. Negative as in USG is only grade 1 ascites. Now, positive, you look for respiratory distress. If there's no respiratory distress, then it's grade 2. That you start on diuretics. The example is spironolactone or furosemide. Spironolactone 400 mg per deciliter and furosemide 160 mg per deciliter. Now, diuretics, usually there's a response, but what if there's no response? Then you do an LVP, which is a large volume paracentesis. Now, large volume paracentesis, what you do is you take in 5 to 6 liters in one go shot. Normally, you don't do this because it causes refractory ascites, but in LVP, you have to do that. But yeah, you should again be careful about refractory ascites as well. Now, suppose respiratory distress is there, then you immediately go for an LVP, where you drain about 6 to 8 liters of fluid removed, and you give albumin IV just to avoid refractory ascites. Now, so you're gonna have an albumin washout basically if you're taking out 6 to 8 liters at once. So you have to give albumin again, or there's just gonna be ascites again. Now we have SBP, spontaneous bacterial peritonitis. Clinical features are fever, rebound tenderness is absent. Okay, rebound tenderness is absent, and there's no local inflammation. So, trap question, rebound tenderness is absent. Now, investigation, of course, you have to see the SAG ratio and ascitic fluid. You have to look for the neutrophils, protein, and culture. Now, SAG is more than 1.1. Neutrophils more than 250 per millimeter cube, and proteins less than 1 gram per deciliter. Culture, most common organism we are going to find in the ascitic fluid culture is E. coli. Now, drug of choice, you have to give third generation antibiotic, cephalosporins like cephaloxime. Now, all patients, you have to give secondary prophylaxis, lifelong, and most common secondary prophylaxis you're gonna give is oral fluoroquinolones. Now, pathognomic for SBBs, neutrophils more than 250 per millimeter cube in the ascitic fluid. Now patient, okay, this is really interesting. So this is an entire one single table. They went into 2 halves, but it's easier if we read it as a single table. Now, steatorrhea. Patient has steatorrhea, fatty stools. Now we do a D-xylose test, positive or abnormal or normal. If it's abnormal, that it means there's a proximal small intestine disease. If it's normal, proximal small intestine is not affected. Now we do a Schilling test, which is absorption of B12. Now Schilling test just tells you if distal is affected. So B12 is not being absorbed. Then there is distal issue as well. But if there is if Schilling test is normal, then distal is not affected. Now let's start with D-xylose test abnormal. So that means proximal small disease is present, small intestine disease is present, and D-xylose test is normal. So abnormal, normal. That means only proximal small intestine is affected, and major cause of that is celiac sprue. Celiac sprue, you do a Marsh criteria on biopsy of the small intestine, proximal small intestine, and most common complication is dermatitis herpetiformis. Most specific antibody for this is anti-TTG. Anti-TTG. Okay, so next we have D-xylose test abnormal and Schilling test abnormal is the entire length of small intestine is affected. Now, if the entire length of small intestine is affected, first thing that comes to your mind is Whipple's disease. Whipple's disease, there's going to be presence of migratory arthritis, past positive macrophages. Now we are gonna go to D-xylose test. Normal. D-xylose test is normal. Schilling test is also normal. That means there's no small intestine is not affected at all. It's just steatorrhea. If the steatorrhea is present, that means small intestine is not affected. That means there has to be something wrong with the fatty acid emulsification. That means there's an issue with your hepatobiliary tree. So bile duct is affected. So there could be a bile duct obstruction, cholelithiasis, who knows. So patient will also have elevated ALP, GGT, pruritus. Now, so the next one you see D-xylose test is normal. That means proximal is not affected, but Schilling test is abnormal. But if distal is affected, then you're gonna say it's tropical sprue. Tropical sprue, you're gonna have hyperpigmented knuckles, mostly associated with COVID. Now, irritable bowel syndrome. Irritable bowel syndrome, we follow the Rome 4 criteria. Main pathogenesis is stress. Now the new update is Rome 5. Includes investigations for calprotectin. Calprotectin should be absent. Now, essential abdominal pain 1 day per week for more than 3 months. Symptom onset is more than 6 months. Plus to at least presence of at least 2 out of 3 First is pain increase or decrease by defecation, change in stool frequency, change in stool consistency, clinical features not seen. So this is a diagnosis of exclusion. You have to consider every other diagnosis first. If that's not there, then you follow the Rome 5 criteria, where presence of abdominal pain for 1 day per week for at least 3 months and symptom onset of more than 6 months, then at least 2 of the 3 criteria, which is pain increase or decrease by defecations, change in stool frequency, change in stool consistency, clinical features are not seen, and calprotectin, stool for calprotectin should be absent. Now, there should not be any weight loss, there should not be blood in stool, there should not be malabsorption. If any of these 3 features are present, then it is okay, outbreak starts in a minute. Good luck, guys. If any of these 3 features are present, then you cannot consider irritable bowel syndrome. Now, most common nosocomial diarrhea, nosocomial Clostridium difficile. Most common antibiotic associated, of course, cephalosporins. Most maximum risk antibiotic is clindamycin. Okay. Most commonly associated is cephalosporin, but if they say maximum risk, it's clindamycin. Diagnostic criteria. Diphtheria. It's for diphtheria. Okay. Loose stool for more than 3 per day for more than 2 days, plus evidence of toxin in stool, PCR, culture, or pseudomembrane. Pseudomembrane is more specific for diphtheria toxin. Now, drug of choice is fidaxomicin, oral fidaxomicin. Fulminant disease. Total leukocyte count should be more than 15,000 per millimeter cube, plus serum creatinine more than 1.5 milligram per deciliter, plus sepsis or toxic megacolon. Antibiotic against toxin, bezilotoxumab. Okay, treatment for fulminant disease, oral and parenteral with vancomycin plus IV metronidazole. Not gonna not remember this. Okay, H. pylori infection decreases the risk of GERD, esophagitis, Crohn's disease, childhood asthma. Also Barrett's esophagus, adenocarcinoma esophagus. Most sensitive investigation for H. pylori infection is, of course, the biopsy urease test. Most specific, however, is culture, and both are invasive. So most sensitive is a urease test, whereas most specific is culture. Best non-invasive treatment is breath urea test. Investigation for treatment follow-up is also breath urea test. Indication for treatment if presence of peptic ulcer, if presence of marked lymphoma. Regimen of choice is, of course, OBMT for 2 weeks, which is omeprazole, bismuth, metronidazole, and tetracyclines. OBMT. Okay, next. We're done with... Oh, that is great. We're done with GI. Now we're moving to CVS. Now CVS, the patient has pleuritic pain, pericardial drop, PR segment is decreased, and ST there's PR segment depression and ST segmented elevation. She's coming from GI to cardia. I need to remember the terminology to use. Because we use increase, decrease, present, not present, normal, abnormal in GI, and when it comes to ECG, you start with increase, decrease again, elevation, depression. Okay, pleuritic pain. So there's pericardial drop. Pericardial drop, big clue already. The ST segment, I don't care about ST segment elevation. PR intervention is gone. This is a case of acute pericarditis, and treatment is only by antidiabetes. So they say pericardial drop, they say pericardial drop, think of acute pericarditis. If they say pericardial knock, think of constructive pericarditis. Knock, cut, see, constructive. That's how I remember it. Another way is rubbed. There's gonna be rubbing. So people find rubbing or massaging an acute sense of relief, and that's acute pericarditis. Next we have Bextrad. which is hypertension, increased AVP, and muscle heart sound we discussed yesterday. So if that is there, then it is cardiac tamponade, and you have to do an emergency pericardiocentesis. So there's going to be pulse electrical alternates, not confused with pulses alternates, which is LVF. So electric alternates. So pathognomic investigation is echo. I mean, you do an EFAST first, but you also confirmatory is echo. RV diastolic collapse, right atrium systolic collapse. So okay, this is a very important question. They're gonna echo findings and cardiac tamponade. There is gonna be right ventricular diastolic collapse and right atrial systolic collapse. Actually, kind of hard to remember. Okay, so one thing we have to remember is there's not gonna be P waves. There's no P waves in a case of cardiac tamponade. Look here, these are T waves, then this followed by a short P wave, followed by a QRS complex. There's no Q wave either, it's just R, and yeah. So this is a case of cardiac tamponade where this RS is right atrial systolic collapse. Because if there is no R wave, then we are gonna go all the way to ventricular fibrillation. VFib. Now, or yeah, we're heart block. If there's no R wave, then it's a heart block, complete heart block. Now, pericardial block, swelling, low voltage ECG. This is constrictive pericarditis. Differential diagnosis restrictive. Cardiomyopathy where S4 is positive. Okay, restrictive cardiomyopathy, S4 will be positive. Now, what's the treatment of constrictive pericarditis? Relieve the constriction, pericardectomy. Now we're down to hypertension. So based on the value of your blood pressure, it can be diagnosed as grade 1 or grade 2 hypertension. Grade 1 is nothing but 140 to 160 by 90 to 100. Grade 2, however, is more than 160 by more than 100. Now, how do you treat grade 1? Based on the presence of comorbid conditions like diabetes mellitus, CAD, or CKD. If you don't have it, then you just start with lifestyle modification, look for 2 weeks. If even after lifestyle modification there's no change in blood pressure, then you start on amlodipine. Unless it's a diabetic, of course, you don't start on amlodipine if it's a diabetic. Now, there is presence of comorbidities, then you don't wait for 2 weeks for lifestyle modification. You do lifestyle modification along with drugs. Now, yeah, as I said, you don't do amlodipine if the patient has diabetes mellitus or CKD. You go for ACE inhibitors like captopril and enalapril. If the patient has angina or hyperthyroidism, easy. You could just go for a beta blocker like propranolol or labetalol. Now, labetalol is safe during pregnancy, by the way. Now, pheochromocytoma, if patient has pheochromocytoma, BPH, easy. Reduce the hypertension. You're going to affect the alpha. You have to block the alpha receptors, alpha blockers. Now we have 3 things called Gordon syndrome, Little syndrome, and Cone syndrome. Gordon syndrome, there's increased BP, there's metabolic acidosis, and there's hyperkalemia with normal RFT. So if there's hyperkalemia, metabolic acidosis, it makes you think of Gordon syndrome. Now you know that the kidneys are affected. What you're gonna give? You're gonna give thiazides. Little syndrome. What is Little syndrome? L for low renin, L for low aldosterone, D for AD, autosomal dominant inheritance, I for increased sodium reabsorption, D for DCK again, L for hypokalemia, and E for early onset of symptoms. So that's little. The answer is in the name. L for low what? Low renin, low aldosterone. I for increase what? Hypernatremia. Yeah, there's going to be hypernatremia due to increased sodium reabsorption. D for what? D for is autosomal dominant. Now, that's another D. It affects the DCT. Now, L for what? L for decreased potassium absorption. Low absorption of potassium, hypokalemia. Now, because of course this hypernatremia, there has to be hypokalemia because of the sodium potassium antipode. Now, what's the E for? E is for early onset of symptoms, and what's the treatment of little syndrome is amyloid. So what's the only vowel that's not in little? Okay, there are a lot of vowels that are in little, but what is the most important vowel that's not in little? It's A. So you give amyloid. You give the A where there's no A. Now next is Cron syndrome, which is primary hypoaldosteronism. We give spironolactone. Now we are done with hypertension. Of course, I'm well thorough with the drugs, so I don't really need to focus on the drugs aspect per se. Drug classification. Let me get some water real quick. Ends up drinking coffee. Okay. Now what do we have here? So there's ST depression in ECG. Troponins are normal. What are we gonna consider is unstable angina. If troponins are elevated, then we're gonna consider NSTEMI. Well, of course, ST elevation, you just go for STEMI, but usually there's ST depression and NSTEMI. Now, treatment for acute coronary syndrome, we give aspirin, clopidogrel, low molecular weight heparin, beta blockers, and nitrate. When do you do a PCI? Based on immediate, early, or delayed? If the patient presents with less than 2 hours and is hemodynamically unstable, he has ventricular tachycardia, he has features of heart failure. If any one of these are present, then you do an immediate PCI within 2 hours of onset. Now, early PCI is within 1 day of onset. You look for troponin, there should be a rising troponin, or there should be new ST changes. Now, delayed PCI is 25 to 72 hours. The patient has diabetes or prior CABG or PCI less than 6 months. If any one of these is present, then you have to do a delayed PCI. Now, in the ECG, you see an ST elevation, troponin is normal. Now, ST elevation, troponin is normal. It cannot be a STEMI. STEMI troponin has to be elevated unless it's early STEMI. Early STEMI, you don't see much changes in troponin, so it could be two things. Now, the patient is young, there's no history of risk factors, and Raynaud phenomenon is positive. Then that's Prince-Metal angina. Now, a patient is old, patient has comorbidities, patient may have previous history of heart disease. Then you're gonna think of early STEMI. Now, treatment for Prince-Metal angina is immediate nitrates followed by calcium channel blockers or alpha blockers. Contraindications are beta blockers, aspirin, and thrombolysis, where you do it as STEMI. Now, yeah, here we go. So I told you the other case where ST is elevated, troponin may be elevated. If it's not elevated, it still could be early STEMI, but the patient is usually old, maybe mid to late age. Maybe he has comorbidities, maybe he has a previous history of heart disease. Now, what you're gonna do? You're gonna start immediate treatment. You have to reperfuse. You have to fix the damaged heart. You have to do a PCI, which is a better option than thrombolysis. Now, door to balloon time. Door is not a patient arriving in the hospital to balloon time is 90 minutes. Symptom onset should be within a day. Door to needle time is 30 minutes. And symptom onset for thrombolysis should be less than 24 hours. If shifting to travel time for PCR procedure should be less than 120 minutes, less than 2 hours. Okay. So now HFrEF, first line drugs to reduce morbidity, valsartan plus carbidopa. So this is the Guardian 4. These are the 4 Guardian drugs, which what is it called again? I forgot. But yeah, you use these 4 drugs for treatment of PCS, a STEMI. So first line drugs is valsartan plus carbidopa, which is the most important drug. Second is beta blockers, that is spironolactone, and third is SGLT2 inhibitors like dapagliflozin and empagliflozin. So there's a new update where you for HFrEF treatment, where you give a non-steroidal MRA, mineralocorticoid receptor antagonist, which is finerenone, which has also proven to be decreased risk in decreased risk of causing gynecomastia. You can give safely and diabetes mellitus and CKD. Now, if ejection fraction is less than 35%, in all patients you do an ICD. If there's wide QRS and left bundle branch block, you do a CRT, which is nothing but cardiac resynchronization therapy. Wide QRS plus LVBB, you do a CRT. Now, talking about LVBB and CRT, we're gonna go to arrhythmias, which is very important. Now, arrhythmias, as we said, there's gonna be a wide QRS complex. Wide QRS complex means there has to be something ventricular. So there is wide QRS complex, there has to be something ventricular. Either you can go for bundle branch block, which is heart block, or there could be an arrhythmia. Now, what are we basing this on? We are basing it on, the first is heart rate. Every time we look at ECG, first look at the heart rate. Is it regular? How many beats per minute? Is it regular, irregular? Just look into it. Is it wide, narrow? How wide is it? If it's wide, then is it more than equal to 3 mm? Now, this wide QRS, increased heart rate, of course, you're going to think is ventricular tachycardia. Now, what type of ventricular tachycardia is it? Now, 100 to 250. Is it monomorphic or polymorphic? Monomorphic, all the height of all the airways should be the same. Polymorphic, all the height of the airways should be different. Now, is it more than 250? If heart rate is more than 250, then it is ventricular flutter. You're not going to make up any waves, nothing. So what is the treatment? Now we have a monomorphic ventricular tachycardia. You check if the patient is stable or the patient is unstable. If the patient is stable, you give amiodarone. If the patient is unstable, you give a synchronized DC shock. Now, patient comes with a polymorphic ventricular tachycardia. Now, if the patient is a polymorphic ventricular tachycardia, the patient is always unstable. And if the patient is unstable, you give an async DC shock. Remember, you give a synchronized DC shock only if the QRS wave is, you can make out the QRS waves. If you cannot make out the QRS wave, if they are not the same, if they're irregular, you do not give a synchronized DC shock. You give an asynchronized DC shock. And that includes both ventricular flutter, because the ECG, the shock machine, the defibrillator, and synchronized, it auto detects the rhythm. But since it's polymorphic or it has a flutter, it won't be able to detect, so it's not gonna give the shock. So you have to do an async shock. You cannot set the basically the rhythm. You cannot set the rhythm in polymorphic flutter. So you have to give an async shock, and the patient is always unstable in polymorphic and particular flutter. Now we talked about white QRS. Wait, not totally white QRS. White QRS has a ventricular or block. Now we're gonna look into the P wave. So the QRS complex is normal. Now we have an issue with the P wave. P wave is present or absent. If P wave is present, so patient is having arrhythmia. Patient is heart rate is above 100, above 150. And now we look at the P wave. Now is P wave present or absent? Now P wave is present. Is each P wave followed by a QRS complex? Now each P wave is followed by a QRS complex, then it's a sinus tachycardia. Sinus tachycardia, usually there's no treatment. You have to just treat the cause behind the sinus tachycardia, which is usually neuropsychiatric sometimes. But sometimes there can also be different morphology of P wave, which causing atrial tachycardia. Then you have to treat the cause. Now, each P wave, now there's P wave present, but each P wave is not followed by a QRS complex. Then what is that? That's an atrial flutter. Now, atrial flutter, usually you have a sawtooth pattern of P waves. So it's going to be like P, 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 Q, P, Q, P, P, Q. So there's not every P wave is followed by a QRS complex. Now, the treatment is same as AFib related. AFib and AFib, you give beta blockers, that's it, based on if it's patient stable or unstable. Now, remember, atrial fibrillation, AFib or atrial flutter QRS is normal, so you can give a synchronized DC shock. That's what I said. Okay, now P wave is absent. You look for the heart rate regular, heart rate irregular. Heart rate regular, it is PSVT. PSVT based on if it's stable or unstable. If the patient is stable, you give adenosine. If the patient is unstable, you give a synchronized DC shock. Now, heart rate is irregular, you're gonna think of afibrillation. If the patient is stable, you give a beta blocker. If the patient is unstable, again, you give a synchronized DC shock. So if there's only one wave between each QRS complex, always consider it as a T wave. Now we're done with arrhythmias. Let's go to ARF, acute rheumatic fever. So there's Jones criteria and Duke's criteria. Duke's is for IE, infective endocarditis, whereas Jones is for acute rheumatic fever. So how do we, so there has to be at least one major plus two minor, or what? I've not commenced. Okay, it's repeats anyway. It's sure. Now, major criteria is, most common major criteria is arthritis. Most common cause of death is carditis, pancarditis. Most common valve involved is a mitral valve. Most common valve dilation is MR, mitral regurgitation. Least common valve involved is the pulmonary valves. Now, it's a direct cause of heart failure. Prophylaxis, primary drug of choice is penicillin, benzathine penicillin. Duration, you give a single dose. Secondary prophylaxis is again penicillin. Duration, if no carditis. Okay, so this is interesting. You look for carditis. If the patient has no carditis, either you give for 5 years or until the patient is 21 years of age, whichever is longer. Now the patient is 18 years, you give plus 5, 20 up to 23 years. If the patient is 21 years, you give up to 26. If the patient now, if the patient is 8 years old, you're gonna give up to 21 years old. Now, carditis is present. You give either up to 21 years of age, or you give for more than 10 years. You give for this 10 years of onset. So if the patient is 18 years and he has carditis, you give for 28 years, up to 28 years. Now, 28 years of age. Now, the patient already has established rheumatic heart disease. He has an established rheumatic heart disease. That means he has either MR, AR, any valvular disease. Then you have to give for lifelong. You can't do anything about it. Now, talking about valvular heart disease, let's get to RHD. Valvular heart diseases. So what do we have? We have MS, MR, AR, AF, AS, AR, TR, TS, and PSPR. So easy to remember. So there's going to be, imagine there's a patient with a pansystolic murmur. Pansystolic murmur means, so the ventricle contracts, and when the ventricle contracts, there is a murmur. So that means either it's going back into the atrial chamber, or there's a murmur, there's an aortic stenosis. So here's the thing. It's a systolic murmur. Now we only have to know if it's an ejection systolic or pansystolic. If it's pansystolic, then it has to be MR. There has to be regurgitation. There's a continuous flow of blood back into the atrium. But now if it's an ejection systolic murmur, so imagine the ventricular contract, it contracts with great pressure, causing the murmur into the aorta, and after that the pressure is relieved, slowly dampening the murmur. So this is called the ejection systolic murmur, which is seen in it's easier to remember like that. It's easier to remember if you know how the mechanism of the murmur works. Now we have a diastolic murmur. Diastolic murmur, again, it could be either due to going up into the one second. So diastolic murmur, this occurs during ventricular filling. So either it could be due to a stenosis, which is going from the atrium to the ventricle, or it could be a regurgitation going from the aorta to the ventricle. So now, just like how we said pansystolic and ejection systolic, there has to be a mid-diastolic and an early diastolic. We're not going to say ejection because there is no ejection, it's a passive process. So early diastolic or mid-diastolic. So the mechanism is pretty much the same. So after the aortic valve closes, there's gonna be regurgitation. It did not close properly. So immediate following pressure, the blood comes back, causing an early diastolic. So remember, aortic is always earlier ejection. Now mid-diastolic, there is ventricular filling of blood, there's passive ventricular filling, and then there's active ventricular filling. So passive ventricular filling should dampen out the murmur, but when there's active ventricular filling, the blood is being pushed from the atria, causing the murmur. So that's a mid-diastolic murmur. So now let's see the other features. In MR, you're gonna see apex displaced. In MDM, there's gonna be a loud S1. In ADM, there's gonna be end-diastolic murmur, or AR. So MS, there's a loud S1. S1. That's how we remember it as loud S1. Whereas the rest have soft S1. Now, aortic regurgitation, there's gonna be a lot of signs. There's a lot of signs for aortic regurgitation, like the lighthouse sign, Urel sign, pulses disference. I don't remember a lot, but I can remember if you say the sign, I can say what it is, but not to remember. Yeah, I can say there's a sign by when you ask me what sign. What is this? I can say what is this, but I just can't remember the names right now. There's one with the liver, there's one with the spleen, there's one with the eyes, lighthouse sign. Then there are two eye signs actually. This is the femoral artery one. Next, aortic stenosis, bicuspid aortic valve ejection click. There's gonna be an ejection click. Now, exactly the same as for TR and PR. Now, treatment always, if it's symptomatic, if it's severe, you do surgery. If it is asymptomatic, depending on the criteria, you can either go for medical conservative treatment but every time permanent as surgery for any valvular disorder. So what is the criteria for severity? First, if for mitral stenosis, if the area is less than 1.5, for aortic stenosis, if it's less than 1, and regurgitated blood is more than 60 ml. Now, surgery of choice, based on regurgitation or stenosis, you do respectively, but aortic valve, always you do a valve replacement. You never do a balloon valvotomy because it's a high pressure system. Aortic valve is a high pressure system, so it's gonna break. You have to do a replacement. There's no other choice, because there's again going to be recurrence and you can't keep doing the surgery. That's pointless. Just do a valve replacement. Whereas for mitral stenosis, you have to do a balloon valvotomy, you open up the stenosis, and for regurgitation, you have to repair the valve. Now, you could do a valve replacement, but it's not necessary. It's not really necessary. It's just a waste of money. Now, infective endocarditis. So here, what we say, the modified Duke's criteria. Most common predisposing factor is MR. Most common congenital heart disease, VSD. Most common cyanotic congenital heart disease is tetralogy valid. Left ventricle affected side brain. Emboli MCA. Okay. Most common non-cardiovascular risk for infective endocarditis is IV drug abuse. Most common community-acquired infective endocarditis is streptococcus viridans. Most common hospital-acquired infective endocarditis is Staph aureus. Time. Okay, it's almost 12:30. Okay, it's been 1.5 hours, and we're almost done with sleepless as well. This is like big progress, honestly. This is really big progress. Now, CNS is really big. Endocrine, I can finish it in the GFE. It's not that hard. But yeah, endocrine does take an hour. Respiratory takes like half an hour max. Respiratory is easy. Respiratory is very easy. It looks big, but it's really easy. CNS is what's most important. This will focus a little down. It's gonna take an hour. Nephral, I don't think it'll take really long because we already gonna cover it in parallel and we're gonna focus on a lot of things. Nephral and rheumat is gonna be quite short. We are done with CS. So post lunch, I think we'll start neuro. Before lunch, let's finish nephral and rheumat as well. And post lunch, we are gonna finish the entire thing. This is probably gonna take 2 hours to 3 hours maximum. I'm telling you, CNS will take an hour. So that's like 2 to 3. 2 to 3 we're gonna consider on CNS. And 3 to 5 we will finish the rest. So 5 o'clock, let's finish. Maximum 6 o'clock deadline, and we are done with medicine. We're still not done with medicine by 6 o'clock. And tonight I'll either do a study stream or we can play more League. Let's see how it goes. Let's see. If I'm in a mood to continue after dinner, then we're gonna keep studying, because I don't know. I have to read OG and I'm really good at it. So every time I read, I just don't feel like, and I started to forget points in Obscine, and now I just don't feel like reading it. So doing that at night is probably like one of those impossible challenges. Maybe if you can focus on some other subject, we can start SPM. SPM is really I can read SPM. It's not that hard. But let's see how it goes. Maybe study a little and then play League. Tomorrow we're gonna play League for sure. That's not a problem. Oh yeah, tomorrow Zaki said he's gonna teach me how to play Lock. He said he's gonna teach me how to play Lock. I'm not gonna learn action. I'm never gonna learn action. I'll learn action only if someone gives me like 500 subs or something. I'm joking, please don't do that. I know some people are crazy. I'm not going to say crazy, not cuckoo crazy, but crazy. See, it's me actually. I'm fucking crazy myself. Okay, now we have. Let's finish. Let's don't waste more time. So most common non-cardiovascular risk for infective endocarditis is IV drug abuse. Most common community-acquired is streptococcus start with. I really wish to stop using the S because when it comes to virulence, I always get confused if it's a staph or a strep. So virulence, most common cause of infective endocarditis, hospital acquired is staph aureus. Always staph aureus. So strep virulence, I do I keep saying staph virulence, strep virulence. Most common cause of infective endocarditis per se is streptococcus group, more than staph aureus, more than streptococcus virulence. Now let's go to prosthetic. Most common prosthetic endocarditis overall is cons. Less than 1 year is cons. More than 1 year is strep virulence. Most common infective endocarditis. Cause of infective endocarditis, IV drug abuse overall is staph aureus, of course. However, left-sided corbet is enterococcus. Left column is enterococcus. But overall, it's still staph. Now, Duke's criteria: two major or one major, 3 minor or 5 minor. So where all you give prophylaxis? This is one more question. Prophylaxis you give in prior infective endocarditis, prosthetic valve, or cyanotic heart disease. Antibiotics for prophylaxis if patient is allergic to penicillin. There's no allergy to penicillin, you just go off the penicillin drugs like amoxicillin and ampicillin. Amoxicillin for oral and ampicillin for IV, of course. Now, he's allergic to penicillin, you have to go for second-line drugs like oral clarithromycin and IV ceftriaxone. Now, let's read the major and the minor criteria. There has been new updates. So major criteria, there are 3 major criteria. One is microbiological evidence like culture physiology, imaging evidence like echo CT, or surgical evidence like during surgery. Its surgical evidence is new, so hopefully I remember this. Minor criteria, predisposing factors like RHD, IV drug abuse, fever more than 38 degrees Celsius, immune phenomenon includes rod spots, RA factor, ocular nodes, glomerulonephritis. Vascular events is nothing but giant dilatation, splinter hemorrhage, and stroke. Now, investigation is not filling the major criteria, and there are 2 additional points that have been added to the criteria: FDG PET scan present and clinically new regurgitation murmur. FDG PET scan positive and clinically new regurgitation murmur. I should send this to Maka. Just 1 second. Yeah, we just realized how to improve the quality of the. Okay, there we go. I think it should be much clearer now. Let me just quickly send this to Mokamin. It's really useful for her exam later. Shift. Okay, to the tiers. Okay, I sent it to Moka. Oh shit. Okay, yes, 1 second. Stand fell off suddenly, I don't know why. This is what I hate about this stand. So unstable. And the blur is fucking insane. The blur is fucking insane. Okay, it's better now. Oh my god. Chad, give me a second. Let me just quickly fix this. The stand keeps falling off. Jesus. And my phone's burning up. Okay, I think this is good now. Just praying it doesn't fall off again. There we go. Okay, I don't really like this murmur table here. But there are a few important things that I've missed out before. Late systolic is always mitral prolapse, and herbs you see AR. Oh yeah, Austin Flint murmur. So MS with AFib, there's gonna be Carrie Coombs. Yeah, there's something I need to look into later. They're not gonna ask it probably. What kind of city there? This. Okay, next is AV block, which they missed again. I had to write down my own notes for it. So QRS is normal or QRS is wide. Now wide, we said it could be the ventricular or the block. Now wide is always 3rd degree growth. Now normal, we have P wave present, P wave absent. P wave is absent, then there could be a sinus arrest. P wave present, you look if each P wave is followed by QRS complex, same as arrhythmia. Now, yes, each P wave is followed by QRS complex, and it's a sinus bradycardia or 1 degree, a first degree block, where PR interval is prolonged. Now, no, each P wave is not followed by PR. There's just PQRS, 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 PQRS. Now, you look for Morbitz type 1 or Morbitz type 2. PR variable, PR fixed. PR variable is Morbitz type 1, PR fixed is Morbitz type 2. Now, normal PR interval is 3 to 5 nanometer. Okay, I wrote a lot here. A lot of this is important, but a lot of this I already know. It's basics. Now, medicine, nephrology, I just don't like anything that has to do with nephrology. It's just confusing. There's so many confusing things in nephrology. I find it a little painful to read as well. Yeah, look at this fucking gigantic table. Honestly, all of this is better explained in Path, so I'm gonna leave it to Path. We have a lot to read in Path. I'm just gonna say, Path is not gonna take, it's gonna take a long time. It's gonna take at least 10 hours without break. That's why I didn't start with Path, because I know if I start with Path, I wouldn't be able to focus. I need to slowly build up, and yeah, OG was a bad idea to try yesterday. We completely fucked up the day because of oops. Although we did finish surgery, so I'm proud of that. Okay, this is important. Difference between CKD and AKI. AKI, the structural, there's no structural abnormality. It's preserved. When structural abnormality is lost, and the structural damage in CKD. Size of kidney is normal of enlarged, shrunken in CKD. Hyaline casts are present. Broad waxy casts in CKD. And metabolic bone disease is never present in AKI, where it's present in CKD. Now, how do we see if it's pre-renal or renal AKI? So most important is FENA, where FENA is the most sensitive indicator. If it's pre-renal AKI, it's less than 1%. In renal AKI, it's more than 2%. Now, serum urea creatinine ratio, normal is less than 12:1. So it's normal in renal, whereas in pre-renal, serum urea creatinine ratio is elevated, so it's more than 20:1. Now, urinary osmolality, that means more concentrated in case of pre-renal and diluted in renal. Urinary sodium is of course elevated in renal and reduced in pre-renal AKI. Now, causes of renal is mostly hypovolemic shock, more than cardiogenic shock, more than septic shock, more than anaphylactic. Whereas renal is always most common is ATN, more common than AI, GN, glomerulonephritis. And GAL is more common, whereas FDA approved is TIP1, IGFBP7, KIM1, and ILD for renal. I have no idea what this is. I just love that. I don't really like this. I just hate this. Okay, indications for emergency dialysis here. I don't think they're really gonna focus on nephrology much on. Okay, exam. It used to be focused a lot before, but now since modalities have improved, it's less of a focus. The most important part of nephrology is the pathology aspect of it, and they are gonna focus on pathology aspect of nephrology. Not much on the medicine, and definitely not much on surgery. Surgery, if they ask, it's gonna be a really hard question. Or if they're either not gonna ask, or if they ask, it's gonna be a really hard question. That's what my manager said. So trying to focus urology in surgery is like a suicide. You have to go in depth. Yeah, I'm gonna distract you a little bit, but we need ask if those 3 times favorite. Which means not healthy, but the healthier version of not healthy, which is still not healthy. And yes, you're gonna hear my every bite, guys. Okay, actually, the more important thing in indication of emergency dialysis is what cannot be removed by emergency dialysis. Example, you cannot give me BCDs, benzodiazepines, opioids, or organophosphorus compounds, and paracetamol. What's your name? The step is important. This is my this is already useful table in this chapter or medicine. I'm not gonna read it all. Nephrology is useful, but in path aspect. I'm gonna read it in path. Path very important. Medicine is just to read a path in a more condensated form. So it's better explained in path, so I'm just gonna read it back. Holy shit, the flavor is hitting my throat. Okay, so RTA, renal tubular acidosis, not for a traffic accident. There's are 4 types, but we did not talk about type 3. Now we're talking about type 3. Type 3 is obsolete now. Type 3 is so obsolete now. That's why they mentioned it separately, because they may ask or may not ask. The flavor. I love the flavor. I love the gochujang flavor. Of course, it's not the exact gochujang flavor that is, but it's a good flavor. It's more of a mild gochujang flavor. I had gochujang before. It's more of a mild gochujang flavor. I think gochujang is more like wasabi. So both, they're not the same taste, of course. But both, when you first eat it, you don't really have that spicy texture, that spicy flavor. But once it sends in, once the aftertaste starts, oh my god, then you now start feeling the spiciness. Unlike ghost pepper and normal peppers. Had some that meeting to ships. Chips. Okay. Give me a second, let me just smack down my fingers a little bit. There's the masala on my fingers. Okay, let me just quickly wash my hand. Does not have a tissue. Okay. Drinking coffee after having anything grocery jar related is a bad fucking idea. It doesn't really see an aftertaste. Like both the tastes got taste mixed up, and it's not this really after bad aftertaste back of my tongue, and I have to drink some water. Okay, now we have the RTA, renal tubular acidosis. Type 1, type 2, type 4. Type 1 is 1 second. How did I forget? I just can't remember. So it's based on the pH. It's just based on the pH, urinary pH. We're talking about urinary pH. Most important to diagnose is urinary pH, not the blood pH, urinary pH. Now, urinary pH is, so there's aciduria. Now, there has to be aciduria to diagnose it as urinary tubular acidosis. Now, there is aciduria, but how much of aciduria is there? Now, if there's always more than 5.5, then it's type 1. If it's more than 5.5 and returns to less than 5.5, then it's type 2. If it's always less than 5.5, then it's type 4. Now, it's always more than 5.5. We're saying it's type 1 RTA or distal RTA. Well, why do you say distal? Because it affects the connecting ducts. So what exactly does it affect? It has to affect the hydrogen ions. It has to affect the H plus K plus ATPase pump and the collecting ducts. So the most common is inherited, less than 10, males more than females. Most common is Sika syndrome, 30% adults are acquired. Drugs amphotericin B, clinical features hypercalciuria. Risk of nephrocalcinosis, rickets, and osteomalacia due to acidemia and hence D3 unresponsive. So the cause of D3 unresponsive rickets or osteomalacia always say distal RTA, type 1 RTA. Now it goes above 5.5 and returns to less than 5.5. What is it? It's type 2 RTA, proximal RTA. So proximal RTA, what happens in PCT? There has to be a HCO3 reabsorption defect. So if that's present on HCO3, it's going to cause aciduria. Now, most common is again inherited, but here is there is some less than 20, here it's 20 to 30, and males incidence is almost equal to female. Now, counter-regulated of course by the hydrogen potassium ATPase pump, hence the acidosis returns to normal again. Now, there's something called Fanconi's triad, or we call it GAP store. Just GAP. What is GAP? Glycosuria, amino aciduria, and phosphaturia. So that's Fanconi's triad or GAP, which we see in proximal. Type 2 RTA, which is glycosuria, amino aciduria, and phosphaturia. So this is the D3 responsive stimulation. Now we have type 4. So we only talked about HK defect in type 1, but what happens if it is a hyper potassium RTA? So why does the hyper potassium RTA? This is because of the aldosterone effect. So there is no reabsorption of potassium. There's no excretion of hyperkalemic RTA. So there is no secretion of potassium due to aldosterone. Yeah. So basically there has to be sodium reabsorption, potassium secretion. This does not happen due to aldosterone defect. And of course, the most common here is acquired. Drugs causing are ACEs, ARBs, trimethoprim, potassium sparing diuretics. It is an incidental diagnosis, and dreaded complication is arrhythmias. We already talked about Gordon syndrome. I don't want to get into it again. Now, we didn't talk about Bartter syndrome. However, Bartter syndrome, unlike what we said, the others is autosomal dominant. This one's an autosomal recessive. Inhibitory effect of the sodium potassium 2 chloride ATPase pump in the thick ascending loop of Henle. So there has to be defective water reabsorption. So yeah, there is defective water reabsorption. So what's going to happen? There's going to be excessive water washout, causing diuresis, fetal diuresis, and hence causing polyhydramnios loss. So what are the other features the patient is presented with? Is 30% present with deafness due to cochlear endolymph concentration, hypercalciuria, risk of renal calculi, and NSAID responsive slows progression as majority causes has limited prostaglandins. Okay. We already talked about gentleman and little, so I'm not going to get into it. Now, rheumatology. I'm just gonna say I don't like rheumatology. I don't like rheumatology. Everything looks the same for me. Everything fucking looks the same. They're all red. They're all swannic deformity. So we are first, of course, if you're talking about rheumatology, always jump into SLE because that's just the first thing you remember. Then the Sika syndrome, myositis, and all that. So let's start with SLE. Wait, let's do the autoantibodies first. So ANA autoantibody is more sensitive for SLE. Anti-Smith is more specific for SLE. Anti-DNA is both sensitive and specific, and also prognostic. APLA APLA syndrome, APLA, risk of thrombosis, recurrent abortions. My mom had a patient with APLA with 8 abortions. Then anti-centromere, specific for CREST syndrome. Anti-topomerase 1, specific for diffuse systemic sclerosis. Anti-Ro, anti-La is for lupus nephritis, for Zika syndrome, basically. Then there is JO1, which is for myositis syndrome. Then RA factor for RA. Then anti-CCP for which is specific and prognostic for RA. Then there's ANCA, which is for vasculitis, ulcerative colitis, and PSA. Now let's go to the lupus disorders versus SLE. SLE you see in middle-aged females, like 20 to 30 years. I'm so sorry, God calling me middle-aged. Leave me alone. I didn't mean middle-aged. That was a slip-up. You guys are still young adult women. Most common feature is synovitis. Most specific features, however, malar and discoid rash. And screening test is ANA. Specific is anti-Smith antibodies, which we already said, and protective. Already we talked about anti-Ro, anti-La. Dreaded feature is heart failure. Now, systemic sclerosis. Systemic sclerosis, now I think this I can say middle-aged females, 30 to 50, pretty old. Most common features is Raynaud's phenomenon. Most specific features, shortening of digits. There's a tits. Oh my god, digits. I mean digits, shortening of digits. Jeez, where is my brain right now? Mask-like face, fish mouth appearance, screening test as ANA, specific antibodies as anti-centromere and topo. For limited systemic sclerosis, anti-centromere, whereas diffuse, we already said isomerase 1. Now, prognostic is antifibrillin, and dreaded feature is pulmonary hypertension. Now, Zika syndrome, Zika, you remember dryness of eyes, dryness of mouth. So, again, same middle-aged females, anti-Ro, anti-La, both for specific and prognosis, and dreaded features lymphoma. That was really good. Now, myositis syndrome. Myositis are three, same myositis, you remember of 3 syndromes. One is polymyositis, one is dermatomyositis, one is inclusion body myositis. Now, so myositis, myo is muscle. So there has to be painful muscle weakness with elevated CPK. So there's ANA, there's CPK, there's Now we have to see which muscles are affected. Is proximal affected or is distal affected? Which is affected more, proximal or distal? Which is affected first, proximal or distal? If everything is proximal first, then you think of 2 things. One is polymyositis, one is dermatomyositis. Polymyositis, there's no skin involvement. Dermatomyositis, derma, skin. Your skin involvement. So polymyositis, again, young female, young adult female. I'm sorry, don't fucking beat me to it. Okay, so no skin involvement, 20 to 30 years. Dermatomyositis, the skin involvement, 20 to 50 years. Female again. All of these females except for, till now we've been talking female, except for one condition, which is distant myositis syndrome, which is nothing but inclusion body myositis, where males are affected more common than female and more than 50 years old age men. No, and here there's no skin involvement again. Now we are done with myositis, we are done with lupus disorders. Now we are getting to inflammatory arthritis. Inflammatory arthritis, again, you remember of 2 things. One is RA, one is seropositive RA, one is seronegative. So let's say seropositive RA, which is nothing but rheumatoid arthritis, fracture positive. So they're gonna be a lot of features like spinal deformity. There's gonna be kneecap pain. There's gonna be multiple joints involved. There's gonna be migratory arthritis. Migratory? Why did I say migratory? Oh my god, that is rheumatoid. That is RF, not RA. They're 2 different things. Now, why do you say it's polyarthritis? And when do you say it's polyarthritis? Polyarthritis is more than or equal to 5 joints involved, whereas polyarthritis is less than or equal to 4 joints involved. Now, seronegative arthritis, again, there are many, but here most important is spondyloarthropathies. where HLA-B27 positive seronegative and predominant is extraarticular. Now, polyarthritis is crystallindius monoarthritis and oligoarth. Monoarthritis gout, great tone more involved in the ankle joint. Oligoarth pseudo gout, knee more affected hip, more affected than shoulder joint. Okay, and how much time do we have? Yeah, after this, let's take a break and I'll come back in like 40 minutes, 30 40 minutes, and then we continue with the rest. So, extra articular features of SPA: onycholysis, psoriatic arthritis, parodermal gangrenism, IBD, keratoderma, glenoragia, reactive arthritis. Unimportant. Vasculitis syndrome. Based on the pathology involved, ANCA-mediated, immune-mediated T-cell. That's not what I already know. Large vessel vasculitis. Large vessel vasculitis, you have GC, Takesius. I don't really want to know. I already know all this. I'm smart. Now, because I've answered so many previous questions on GC and Takesius arthritis, and so I'll get repeated in past. So I do not keep reading again and again. All this is repeated already in past. Yeah, I think we're just gonna skip it up. I'm gonna come back in 40 minutes. We're gonna come back in 40 minutes and then we continue with CNS. Guys, trust me, we are already halfway. Endocrine is easy. Endocrine will take like half an hour. I already read it twice because I was struggling with endo. So now I'm perfectly fine with it. Respiratory medicine gets over really quickly. CNS is the major thing. CNS is big. CNS is huge. It does not look huge here. It looks like way few pages, but it has a lot of content to read in it. Like, really look at the font size. It's really small. Okay, so yeah. After this, we're done with medicine. We're gonna be done with medicine in 4 hours. So I will be back and where's the text? 40 minutes break. I already did a 40 minutes break before. Okay. So BRB guys, I'm gonna make myself enjoy.
Just the way you do it makes me cry all night. I just love your smile. Just the way you do it makes me cry all night. Baby, I just love the way you smile. It's that smile that makes me wild. And every time you really smile for me, yeah, I feel so invincible. I just love your smile. Just the way you do it makes me cry all night. I just love your smile. Just the way you do it makes me cry all night.
恐れるな。これがお前の決めた道だろう。お前に比べれば我らの痛みは一瞬で終わる。
分かってるわ、イタチ。
最後に約束しろ。
分かってるわ、イタチ。
came from Brazil.
Hey Sparkles, let's start again. Give me a second, let me just set things up pretty quick. Okay. Psychic eyes. Okay. Anything? Should change the camera real quick. Oh no. Oh no. I broke it. I broke the one needed for adjusting the height. Oh no. The stick's broken. The stick is broken. Oh yeah, this is so disaster. Yeah, I don't think we could do webcams anymore. We can do hide cams anymore. The stick's broken. The stick for adjusting the angle of the camera is phone is broken. I was trying to adjust it and it snapped. The stick just snapped. The stick just snapped. I don't know how to do this on the stick. It's not possible to do that on the stick. What to do it on the stick? Okay, I think it's better now. And then better. Basically, not. Oh god. Yeah, it's a mess. It's a fucking mess. I'm trying to fix this with the broken stick, but wait, I don't know. I think that's better. Yeah, much better. Fine. Okay, welcome back, guys. Welcome back. Second screen time. Okay. It's fine now. It is fine now. I think you would be able to see a part of it, part of the book, but I think it's the bottom of bottom. Too important. Or too important. Well, let's do this. I'm trying to boss so bad. Like a little day already. Okay, medicine. We are officially in medicine. That being in CNS. So there's 4 types of seizures. There's absence seizures, there's focal seizures, there's GTC, and there's JMA, juvenile myoclonic epilepsy. Now, let's start with GTCS. Let's start with absence, but I think it's better to start with GTCS because more important. Now, GTCS is a loss of consciousness with tonic stiffening with clonic jerking, followed by post-ictal confusion. Associated features may have tongue bite, urinary incontinence, frothing at mouth, and tongue muscle soreness after the attack. EEG findings show generalized spike in wave, polyspike activity between attacks. Neuroimaging does not rule out secondary causes. Treatment is valproate and lamotrigine. Now, focal seizures arises from a localized area of one cerebral hemisphere, with or without impairment of awareness. Presence of an aura is a key clue for focal onset. Then spread progresses to bilateral. First is lateral, then progresses to bilateral tonic-clonic. Management, lamotrigine, lamotrigine. You can give oxcarbazepine, carbamazepine, levetiracetam. Safest is lamotrigine. Oxcarbazepine causes hyponatremia. Levetiracetam is used in elderly. Now, absent seizures, so petit mal epilepsy. Petit mal means small children. Or also called pycnolepsy. So this brief sudden staring for 5 to 15 seconds with no post-ictal confusion precipitated by hyperventilation occurs multiple times a day and mostly seen in children. Characteristic 3 hertz spike and EEG. Treatment drug of choice is ethosuximide. Ethosuximide is a drug of choice. Alternative, we can give alpha-later lomotriptan like GTCS. Now you have to avoid carbamazepine and phenytoin because they worsen it. Now JME, juvenile myoclonic epilepsy, early morning myoclonic jerks in adolescents, often leading to dropping objects precipitated by sleep deprivation, stress, and alcohol. EEG finding characteristic 4 to 6 hertz polyspike wave discharge. Drug of choice is valproate. Again, just like GTCS, you give valproate. Alternatives, again, you can get lamotrigine or letrozole. Again, you have to avoid carbamazepine and phenytoin because they worsen the myoclonus. The JMB and typical absence seizures, CT-MRI is always normal, so EEG is used to differentiate. Whereas focal and GTCs, you always have to do imaging to rule out other causes. Now, status epilepticus, it's a neurological emergency. Ouch. As continuous seizure activity for more than 5 minutes or interictal loss of consciousness for more than 30 minutes. So either the seizure has to last more than 5 minutes or the loss of consciousness has to be more than 30 minutes. So if he has seizures, then it's convulsive. If he has only loss of consciousness, then it's non-convulsive. Now, clinical hallmarks, as we already said, more than 5 minutes, failing to gain consciousness between seizures, associated with high morbidity and mortality. So key investigations you have to do are blood glucose, ABG, and electrolytes. Along with that, you have to do EEG, you have to do neuroimaging, you have to do neuroimaging and CT and MRI to identify structural cause. Now, management, you have different protocols. You have like 0 to 5 minutes, 5 to 10 minutes, 10 to 30 minutes. And then refractory, 0 to 5 minutes, you first do the every breathing circulation, IV access, blood glucose, 5 to 10 minutes, you inject IV lorazepam and diazepam. 10 to 30, if it does not settle, then you give phenytoin or phospheniton or levetiracetam. Then last case scenario, you have to sedate the patient, self-induced coma by induced coma by infusion, medas infusion or propofol, and then ICU care. So that's more than 30 minutes. So first, you 5 to 10 minutes, you do all the necessary checkup. Then 5 to 10 minutes, you give IV lorazepam, then diazepam. Then 10 to 30 minutes, you give IV phenytoin, levetiracetam. When refractory is medas or propofol. Now, epilepsy in pregnancy, you have to rule out eclampsia. Now, clinical hallmark may lead to maternal uncontrolled seizure, may lead to fetal distress or maternal distress. Now, there's risk of certain congenital malformations with certain AEDs like valproate. So, seizures may increase or decrease or remain the same. Then key investigations: serum AED levels, antiepileptic drug levels, US ultrasound anomaly scan, drug levels during each trimester, level 2 anomaly scan at 18 to 20 weeks. Then do a lot of eclampsia, as I told before. Now, management is by levetiracetam or lamotrigine, as I already told before. Valproate is avoided in risk of neural tube defects. Supplement high dose folic acid, 4 to 5 grams per day. So what you can do is you can give phenytoin twice a day instead of twice a day. Instead of once a day, but you usually take 300 mg at night. Instead, you can divide it to 100 mg, 100 mg twice a day to avoid toxic doses. Next, now we have movement disorders. This is based on the lobus pallidus and the what's that? Second. So based on where it affects predominant global spiders, you can tell what kind of movement also arrives. Now we have four basically: chorea, ptosis, balismus, and dystonia. Now chorea is rapid, irregular, purposeless dance-like movements. Where does it affect? It affects the striatum. I drew a nice diagram here. So GP, global spiders is affect ptosis affect dystonia. No, dystonia is predominant, no? Oh yeah. Predominant is dystonia, global pallidus is acetosis, chorea is striatum. Then we have the subthalamic nuclei, which causes a hemibalismus. Yeah, this is just in my head. It's just in my head. I remember it. I just remember it. So chorea, dance-like movements, striatum, due to dysfunction of the striatum, causes Huntington disease, hidden chorea, drugs like levodopa. Movements disappear during sleep. Now, acetosis, lesion of the globus pallidus, the snake-like breathing movements, predominantly distal limbs. Often overlaps the chorea ptosis. Now, hemibalismus or balismus lesion affecting the subthalamic nuclei, sudden violent flinging-like movements, distribution usually unilateral, most commonly due to contralateral stroke. Now, dystonia, sustained muscle. Dystonia is nothing but twisting postures due to mainly basal ganglia lesion in the putamen, basically. Now, focal, segmental, or generalized, improves with sensory tricks like gest antagonist. Now, chorea with family history and dementia, you're going to think of Huntington chorea. Investigation, you have to do MRI, you're going to see boxcar ventricles. Now we have dystonia with peripherals, acanthocytes and peripherals mirror. So the answer is the question, neuroacanthocytosis. Next, chorea, Parkinson's with levodopa. Levodopa, what did they say? Chorea, drug-induced chorea. Levodopa-induced chorea. Now, chorea carditis, arthritis. Now, chorea carditis, arthritis, remember we did talk about it in RF. So it's going to be Sydenham's chorea or rheumatic chorea. Now, chorea in chorea female hyperemesis, that's going to be chorea gravidarum. Now, acanthocytes you see in two, we've already discussed about it. One is in alcoholic liver disease and one is in neuroacanthocytosis. And third one I forgot is A-beta-lipoprotein. Now, Parkinsonism, pathogenesis, degeneration of that dopaminergic neurons in substantia nigra compacta, dopamine and nigrostriatal pathway, imbalance between dopamine and acetylcholine, leads to overactivity, blah, 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 presence of Lewy body, alpha-synuclein aggregates, and idiopathic Parkinsonism. So there's typical Parkinsonism, there's atypical Parkinson's. Now, this is what we're talking about. Typical etiology is idiopathic drug-induced toxins trauma. Idiopathic is the most common drug-induced, includes antipsychotics, metoclopramide. Toxins include carbon monoxide, manganese, MPTP, and heroin addicts. Trauma, especially in boxers. Now, clinical features, they call it TRAP, thermogestic trauma is called wheel rigidity, akinesia, bradykinesia, postural instability, mouse-like face, micrographia, shuffling gait, and wrestling gait. I forgot to take my medicines. I'll take it. Now, treatment of Parkinson's. So you have to restore the acetylcholine dopamine balance. And how do you do that? You have to increase the dopamine. So dopaminergic therapy, you give levodopa, carbidopa, which is the gold standard therapy, most effective for bradykinesia and rigidity. Now, what are the other? Or if not, you can't give dopaminergic agents. Now, what are you gonna do? You're gonna give dopaminergic agonists. which are gonna promote the synthesis of dopamine. Example, ramiprozole, roniprolol, rotigotine. Now, enzyme inhibitors includes MAO-B and COMT inhibitor, MAO-B like cerebrine, and COMT inhibitors like capone. Anticholinergic THP, good for tremor in young. There's new therapies like deep brain stimulation indicated in advanced Parkinson's disease. One of my viewers had advanced Parkinson's, who had undergone DBS last year. But I haven't really talked to them in a while. But yeah, I remember they did undergo DBS for advanced Parkinson's. I hope they're doing okay. Now, libido always for food, avoid B6, decarbox, increase decarboxylation. Now, tremors. With tremors with levosalbutamol, atropinic tremor, family history of tremors happens with anxiety or decreases on alcohol intake. That's nothing but essential tremors. Treatment is by beta blockers, ataxia plus nystagmus, this is cerebral lesion. Tremors with alcoholic intake and tremors that swapping tremors seen in ALD, and which indicates alcoholic encephalopathy. Now, tremors with exophthalmos head heart rate, that's clearly Graves' disease, cytotoxicosis. Now, atypical Parkinsonism, we basically have four. One is progressive supranuclear palsy, one is multiple system atrophy, then there's dementia with Lewy body, and then there's cortical basal degeneration. Ad break start in a minute, so hold on tight. So the first thing we're going to talk about is progressive supranuclear palsy. It's basically a vertical gaze palsy. It's looking downward, early postural instability, and false axial rigidity, more common than appendicular rigidity, and staring look, gunslinger gait with wrinkles. Now we have multiple system atrophy, where multiple system autonomic, early autonomic failure, cerebral Alzheimer's, Stridor stapleton, poor liver appearance. Now we have DLB, dementia with Lewy body, is one of the dementia with Alzheimer's. So dementia proceeding within 1 year of Parkinson's, visual hallucinations present, fluctuations in cognition, extreme sensitivity. This is not synapse, but this is the only difference. Now, CBD, what is CBD? Cortical basal degeneration, asymmetric rigidity, and dystonia, alien limb phenomenon, cortical sensory loss, and apraxia. This is one page I read. I keep forgetting. Like, I just don't remember atypical Parkinson's. It's really hard. Now, PSP, vertical gaze palsy, axial rigidity, staring look, gunslinger gait, MSA, you have autonomic failure, cerebral signs, whatever response. Now, DLB, we have within 1 year dementia, digital hallucination, fluctuations in cognition, and extreme sensitive neuroleptics. Now, CBD, cortical basal degeneration, asymmetric rigidity and dystonia, alien limb phenomena, cortical sensory loss, and apraxia. Now, differences between Parkinson's disease and atypical Parkinson or Parkinson plus. Now, onset Parkinson is always asymmetric onset, whereas Parkinson plus is a symmetric onset, rigidity limbs more than spine, whereas Parkinson more than appendicular. Atypical dementia more than equal to 1 year, whereas Lewy body dementia within 1 year of onset of Parkinson's. Now, response delivered up is good in case of Parkinson and Parkinson plus, where we already saw. In case of MSA, there's poor dopa response. Now, gait, short strides, dementia, and urinary incontinence. If there's urinary incontinence in it has to be NPH, normal pressure hydrocephalus for this. Now, there's ataxia, confusion, and ophthalmoplegia. Ophthalmoplegia, confusion, ataxia. That sounds like Wernicke's encephalopathy, having deficiency. Now, ataxia, areflexia, now we talked about confusion and ophthalmoplegia, but if they say ataxia, ophthalmoplegia, and areflexia, so this is very tricky. Sometimes you often miss out the areflexia. If there's areflexia, then it's Miller-Fisher syndrome and not Wernicke's. They're gonna put both options. They're gonna put Wernicke's and Miller-Fisher, but if there's confusion, it's Wernicke's. If it's areflexia, it's Miller-Fisher. Now there's ataxia, areflexia, and watch out. It's not ophthalmoplegia, but it extends our plantar reflex. If the extensor plants are reflex, then you have to look for two things. One is vitamin B12 and one is vitamin E. Now, if there's low vitamin B12, then it could be SACD. Now, if there's low vitamin E, then it could be Friedreich's ataxia. Now, ataxia, reflexia, it's not extensor, there's flexor plantar reflex, which is normal. And then there is ARP. If there's ARP, then it's neurosyphilis or tetanus dorsalis. Now, exorcism supplementation can cause hypocupric myelopathy, which is similar presentation to SACD. Okay. So let's do it again. Now, gait. We have shorter strides, dementia, and urinary incontinence, then pH. Now, ataxia, confusion, and ophthalmoplegia, Wernicke's encephalopathy. Now, ataxia, reflexia, and ophthalmoplegia, that it is Miller-Fisher syndrome. If it is ataxia, reflexia, and extensor plantar response, then you have to think of low vitamin E or low vitamin B12. If it's low vitamin E, then it is Friedreich's ataxia. If it is low vitamin B12, then it is SACD. Now, if there's ataxia, reflexia, flexor plantar, and ARP. If there's ARP, then it's tetanus dorsalis or neurosyphilis. Now, excessive zinc supplements are similar to SACD, which is hypocritic myelopathy, which has decreased copper absorption. Now, we're done with that. Now, next is arterial localization. So you have AC infarct, MCA infarct, and PCA infarct. Now, anterior cerebellar artery. First, you need to know where does each supply. So this is a figure of a man. Spread his legs, make an A with it. I use the arms as an M and the mouth as an M and the eyes as P's. So ACA. Where do we have A's here? There's only one. There's lower limbs. So AC infarct, there should be a contralateral leg weakness more than an arm weakness. So there's A, he's spreading his legs, which also means there's urinary incontinence, and he's spreading his leg. That means he has behavioral issues like personality change, apathy, ablelia. Then the other one is gait apraxia, frontal lobe signs like primitive reflexes. So he's spreading his leg like a monkey. So he's primitive reflexes. Now, next is PCA. Let's go ahead and see it. Well, that's because it's bigger. So PCA, remember that eyes, ophthalmic, wait. So mainly it affects the eyes. So let's see what all happens in this. So there's occipital lobe involvement causing homonymous hemianopia with macular sparing. There's cortical blindness, bilateral PCA infarct, and there's Anton syndrome. Dense blindness, Anton syndrome. Now, there's thalamic branch involvement causing contralateral hemisensory loss, and Dijon-Rossi syndrome, which is nothing but thalamic pain on recovery. Dijon-Rossi syndrome, which is thalamic pain on recovery, which you see in a PC infarct. Then there's midbrain involvement, which is Weber syndrome with ipsilateral oculomotor palsy. Weber syndrome, ipsilateral oculomotor palsy. Now, that is P. Now, we have M. So where all do we have? When we have M, facial nerve. Then we have M, which is arms. So contralateral face and arm weakness, gaze preference towards the side of the lesion, homonymous hemianopia, dysarthria with aphasia. Now, dominant hemisphere. Broca's left dominant hemisphere, if you have lesion infarct, so what are going to be affected? Broca's aphasia, frontal operculum involvement, Wernicke's aphasia, temporal lobe involvement, lobular aphasia, and Tarrant's territory. Now, let's see based on the division of the artery where what all is affected. Now, superior division of the artery is affected. You're gonna face a weakness with Broca's aphasia. Now, inferior division is affected. It's gonna go to the temporal lobe. So, Wernicke's and field effect. Now, deep perforator, you're gonna have a pure motor stroke, dense hemiparesis. Now, since we moved into aphasia, let's talk about aphasia. There's Wernicke's, Broca's, conduction, anomic, pure word deafness, pure word blindness, and transcortical aphasia. Now, Wernicke's aphasia is seen in the temporal lobe. There's fluent speech, but incoherent speech. Severely impaired comprehension. Patient is not aware of the defect. Lesion is located in the superficial temporal gyrus, superior temporal gyrus. Now, Broca's aphasia patient is non-fluent, effortful, and comprehension is preserved. Patient is frustrated because he's putting in so much effort, and it's located in the inferior frontal gyrus. Area 44. Now, conduction aphasia. Conduction aphasia impaired repetition. Conduction aphasia is the arcuate fasciculus connection between the Broca's and the Wernicke's. So there's gonna be fluent speech with phonemic errors, comprehension is preserved, and there's impaired repetition. So it's still gonna be effortful, but fluent. Now, anomic aphasia. Anomic is nothing but word finding difficulty, which is a hallmark feature. Speech is fluent and grammatically correct. Comprehension repetition remains intact. The lesion lies in the angular gyrus or the temporoparietal junction. Now, pure word deafness. Pure word deafness is patient can read, write, speak, but he cannot. He has normal hearing, but when it comes to comprehension of spoken words, it's impaired. So he cannot recognize speech sound, but can recognize non-speech sounds. And now, where is the lesion? Lesion is in the bilateral superior temporal lobes. Bilateral superior temporal is origin language areas. It's located in the bilateral superior temporal lobes. Now, pure word blindness. He can write. Writing is preserved. He can hear. He can speak, but he cannot read. Now, often associated with right homonym is hemianopia and lesion in left occipital lobe plus splenium of corpus callosum. Now we have transcortical aphasia. Repetition is preserved in all transcortical aphasias, motor type. Non-fluent speech with good comprehension. That's similar to Broca's, but repetition is intact. Sensory type is similar to Wernicke's, but repetition is intact, and mixed is both Broca's plus Wernicke's. So, can a patient with Broca's or Wernicke's write a dictation? He cannot. Patient cannot speak but can sing Broca's. Aphasia plus depression is seen in Broca's. Aphasia plus neologism is seen in Wernicke's. Stammering is hyperkinetic dysarthria, Tourette syndrome, and scanning dysarthria in cerebellar ataxia. Now, we're halfway there. I think we're halfway there. Now, thrombolysis and ischemic stroke. Standard window within 4.5 hours of symptom best result in 4 hours. Target time is needle time is less than 60 minutes by 90 minutes in case of PCI. Now, standard mechanical thrombectomy standard up to 6 hours, extended up to 24 hours. IV thrombolytic agents, what all we use? We used alteplase and tenecteplase. Alteplase dose 0.9 mg per kg, 10% bolus, and rest over 90 minutes. Blood best is tenecteplase is only single dose, 0.25 mg per kg, single IV bolus dose. Better for thrombectomy candidates. Now, absolute contraindications are you don't give in the case of intracranial hemorrhage, you don't give if there's very high BP, like 185, 110, you have to first bring down the BP. Now, recent intracranial surgeries, higher trauma, if there's thrombocytopenia, if there's activated nerve defined as more than 1.7, and large established infarct. Now, relative contradictions are recent surgeries within 2 weeks, the recent GI bleed within 3 weeks, and severe hyper or hypoglycemia. You can correct the hypoglycemia, and then you can do the thrombolysis. So the BP value should be less than 180, 185, 110 before, and 180, 105 after thrombolysis. Every minute untreated, you lose around 1.9 million neurons. So now we have moving from thrombus to hemorrhage. Now, where all can hemorrhage occur, there can be a hemorrhage in the basal ganglia, there can be hemorrhage in the thalamus, there can be a pointed hemorrhage, there can be cerebellar hemorrhage. But how are we going to differentiate all of them? Basal ganglia hemorrhage, you're going to see contralateral hemiplegia, both face, arm, and legs are equally involved, gaze deviation towards the side of lesion, similar to what we said, MC stroke. Now, because decrease consciousness typically causes chronic hypertension. Now we see thalamus what all are involved. You see sensory loss, you see vertical case palsy. That's how we talked about DRS, which is not F1 but digital drowsy syndrome, thalamic pain on recovery. Now plantar hemorrhage. Plantar hemorrhage, you see plantar hemorrhage, you often see quadriplegia, you see decerebrate. Okay. So there's two, there's decorticate portion, decerebrate. Decerebrate is seen in plantar hemorrhage, decorticate is seen in Marie-Tooth syndrome. Now, wait, was that right? Yeah, lateral medullary syndrome, you see decorticate. Decerebrate you see lower under the below the red nucleus, which is pontine hemorrhage, saline coma, pinpoint tubules, quadriplegia, decerebrate poisoning. Now you don't treat a pontine hemorrhage, patient can lead to respiratory distress due to present respiratory and cardiac center. Now cerebral hemorrhage, ataxia, vertical vomiting, nystagmus, rapid deterioration, risk of hydrocephalus. Now we're done with ICH. Now let's go to SAH. SAH, why does SAH occur? Due to spontaneous rupture of berry aneurysm, which we discussed yesterday. Or AVM malformation, trauma is the most common cause. Common aneurysm sites is anterior communicating artery before the MC bifurcation, and then the posterior communicating artery. If the posterior communicating artery is involved, it goes behind the occipital lobe, so third cranial nerve should be affected. If MC bifurcation, then you know it goes to the temporal lobe, and then you don't know where the keys and stuff. Whereas if the anterior is affected, then you're gonna have bitemporal hemianopia. Now, clinical features, thunderclap headache, worst headache of life, vomiting, photophobia, loss of fluctuation of consciousness. Management signs, you're going to see cardiac insufficiency sign, no focal deficits. Now, treatment is to endovascular coiling or surgical clipping. You give nimodipine to control to prevent vasospasm, so that you don't lose more neurons. Now control BP at 160 at 90, or there's going to be refractory hypotension. Now manage hydrocephalus with CN, not refractory hypertension, but you have to. It's called permissible hypertension, because less than that, then your brain is going to lose blood supply. Then manage hydrocephalus with CSF drainage if needed. Treat raised ICP and seizures. Major complication, I said vasospasm if you don't give nimodipine, morbidity, rebleeding causes mortality, hydrocephalus, hyponatremia, cerebral salt waste. Hyponatremia due to cerebral salt wasting syndrome. Now we have a case of SAH. The patient has hemiparesis and MRI shows MCA infarct. What do? You should not do thrombolysis because it can cause worsening of SAH. That's why you give nimodipine. Now, patient has SAH. He's in later goes into coma, and so he's normal first, and then he later goes into coma. So that means it's a re-rupture. Now, patient has SAH. He has thunderclap headache. He has papilledema, raised ICT. That means patient has hydrocephalus. Now he has SAH and he has fatigue. Fatigue means he has salt wasting syndrome, cerebral salt wasting syndrome. That means hyponatremia. Now, myasthenia gravis. Myasthenia gravis, you often, there's two things. This one is myasthenia gravis, there's one is LEMS, which is Lambert-Eaton myasthenic syndrome. So both are exactly two opposite things. Let's go with myasthenia gravis first. So myasthenia gravis has fatigable weakness, worsens with activity, and improves with rest, worsens in the evening. Ocular symptoms, ptosis, diplopia, most common initial sign, bulbar weakness, dysarthria, dysphagia, nasal speech. Proximal limb weakness, more common first and then distal. So it goes proximal to distal, and the sensation and reflexes usually normal. Evening resting, classical clue. Now, investigations, you do anti-acetylcholine receptor antibody. Repetitive nerve stimulation should cause a decremental response. Single fiber EMG should cause increased jitter, which is most affected. CT, MRI, chest, urolog, thymoma. IcePack has new stigmatase bedside clues. Now, treatment is acetylcholine esterase inhibitors like pyridostigmine, which is the first line. Then you have other immunosuppressants like steroids, azathioprine, then thymectomy, indicating thymoma. In young patients. Myasthenia gravis is usually young patients. Patients die by the age of 20 due to respiratory distress. Now, myasthenia crisis, IVIG, or plasmapheresis with ventricular subgroup. Mainly due to respiratory, a patient dies due to respiratory paralysis in his late 20s. So avoid drugs, aminoglycosides, beta blockers, fluoroquinolones. Okay, now we have Lambert-Eaton myasthenic syndrome. So here you have antibodies, autoantibodies against presynaptic P by Q type voltage gated calcium channels causing decreased acetylcholine release and NMG. Okay, we're almost done. You have like 6 more pages. And then we have respiratory system. Why is respiratory system so big? Like, it has so many pictures and flowcharts, that's right. It occupies most of the space for absolutely no reason. So again, it's all X-rays, huge, giant X-rays, gigantic flan pics. So it looks big, but it gets over in a jiffy. The prof just wanted to make it look big so that he can take the entire day to teach and chill. Okay, so we were at LAMS. LAMS is autoantibodies against presynaptic P by Q type voltage gated calcium channels causing decreased acetylcholine release at NMJ. So that's going to be proximal muscle weakness, which improves with activity, and there's presence of autonomic symptoms, which is not seen in myasthenia gravis. So like dry mouth, impotence, strongly associated with small cell lung cancer. Treatment is by 3,4-diaminopiridine, treat underlying malignancy plus immunotherapy if needed. Now, there's a table that I don't know if you guys can see this. I think it's covered. Difference between MG, myasthenia gravis, and LEMS. Weakness in myasthenia gravis first is initially always ocular, then facial, then skeletal, whereas LEMS is full skeletal, facial, ocular involvement is rare. Next, worsens on exertion, whereas LEMS improves on exertion. DTR, deep tendon response, normal in terms of myasthenia gravis, decreased or absent in presence of LEMS. Bladder is autonomic is normal in MG, whereas LEMS autonomic nervous system is inward. Associated thymoma here is also with small cell lung carcinoma. Now, repeated nerve stimulation, decremental in MG, whereas incremental in LEMS. Higher dosage mean is a treatment of first-line treatment in MG, whereas in LEMS at 3,4-diaminopiridine. Now, GBS. So GBS is nothing but acute autoimmune demyelinating polyradicular neuropathy, often triggered by prior infection causing molecular mimicry. Most common trigger is campylomatosis. Now, what happens is there are antibodies acting against the peripheral myelin, causing demyelination and conduction block. Now, there are different variants like AIDP, which is more common. There's AMAN, there's AMSAN, there's Miller-Fisher syndrome. Miller-Fisher syndrome we already discussed before, right? There's areflexia, there's ataxia. Missing something. Ophthalmoplegia. So clinical features. There is ascending symmetric flaccid paralysis starting from the legs, areflexia, hyperreflexia, mild sensory symptoms, paresthesia, sensory loss, cranial nerve, facial diplegia, Miller-Fisher triad, ophthalmoplegia, ataxia, areflexia, which we just said. No sensory level plus normal body initially, such as GBS. Now, investigations. You have to do NCS, no connection study. Treatment, first-line treatment, IVIG plasmapheresis, supportive advantage monitoring, DVT prophylaxis, physiotherapy, steroids are not useful. Now, we have difference between GBS and myelopathy. GBS, there's motor deficit more than sensitive, and myelopathy is both motor and sensory deficit. Autonomic control in GBS is normal, just like in myasthenia gravis. But in myelopathy, you have involved a autonomic system. Sensory level is normal, no sensory loss, but multiple sensory level is involved. C5 is bisexual. If bisexual turns to be negative, then you have to put them on ventral support because C5 civics also supplies the phrenic nerve. So if the phrenic nerve is impaired, then there's gonna be arrest, diaphragmatic arrest. Now, migraine. So this we can finish first. Migraine triggers sleep disturbed dietary triggers, fasting, skipping meals, cheese, chocolate, MSG, caffeine, alcohol. Hormonal changes, menstruation, OCPs, environmental factors, bright lights, loud noise, small smells, clinical features, recurrent unilateral throbbing headache, nausea, vomiting, may have aura, may or may not have aura, acute treatment. Acute treatment, first you give diclofenac, ibuprofen, you give triptans like sumatriptan and rizatriptan, antiemetics like metoclopramide or peria. New options here, CGRP antagonists like rimegepant and obiagepant. Severe attacks, you give IV antiemetics and hydration. Now, prophylaxis, drugs used, you can give amitriptyline valproate, which is anti-epileptics, amitriptyline, which is TCAs, you can give propranolol, you can give calcium channel blockers, flunarizine, CGRP, we already discussed, CGRP monologues like rimegepant and obiagepant, which is mostly for refractory migraine. We have tension headache, which everyone fucking have, treatment is by paracetamol. Now, cluster headache, pain pattern severe unilateral periodic temporal pain, disturbance excruciating swiping lasting 15 to 180 minutes, autonomic fissures, ipsilateral lacrimation, congenital injection, nasal congestion, rhinorrhea, ptosis, meiosis, which is ptosis and meiosis ordinary syndrome, periodic clustering, uncrescent clusters, is specific pattern. Treatment is by hyperbaric oxygen and giving subcutaneous sumatriptan. Prophylaxis, you have to give a permit, which is a drug of choice, verapamil. Now remember, bilateral headache, dull aching, papillary edema is nothing but raised ICT, hydrocephalus, or tumor. Now, pyogenic meningitis. Pyogenic meningitis, most common cause in children is Neisseria meningitis, but in adults it's streptococcus pneumoniae. Now, clinical features, classic type of fever, neck stiffness, and headache associated with altered sensorium, vomiting, photophobia, seizures. Now, CSF findings, we have turbid CSF, increased neutrophil, low glucose, increased lymphocytes, is in tuberculous meningitis. Here you have neutrophil predominance and hypertension. Now, treatment, you have to give IV broad spectrum antibiotics and antibiotics immediately, which is like ceftriaxone, vancomycin, ampicillin, and you have to do culture, and based on that you can modify the treatment. Now, give dexamethasone before or with first antibiotic dose. Now, tuberculous meningitis, pretty much same as. So there's going to be base cell meningeal inflammation, hydrocephalus, similar to pyogenic meningitis, but with lymphocyte predominance and positive AFB CP9 culture. But treatment, you give anti-ATT, HRZD followed by HRE24. Now, you can give steroids to reduce inflammation and complication like dexamethasone. Now, cryptococcal meningitis. Cryptococcal meningitis caused by cryptococcus neoformans in HIV patients with CD4 to 700. Now, maybe in immunocompromised. Now, clinical features: we headache, altered sensorium, fever, seizures, raised ICT. Now, clinical features: raised open incursion, lymphocytic predominance, mild increase in protein, decrease in glucose, India ink stain, cryptococcal nigrans, cryptococcal antigen in CSF serum, highly sensitive. So there's going to be cryptococcal antigen positive, highly sensitive. Now, treatment is by amphotericin B and fluconazole. So consolidation phase, you can get fluconazole. Now, HSV encephalitis up is most commonly HSV1, HSV2 is genital. Now, predominant was a temporal lobe, acute onset fever with altered sensorium, behavioral changes, hallucinations, psychosis, seizures, often focal. Aphasia, minorias due to temporal lobe involvement. Investigations, MRI, brain hyperintense lesions in temporal lobes. CSF PCR for HSV DNA, most sensitive. CSF lymphocyte proteocytes as well. Treatment is by acyclovir. Now we have fever, headache, neck. This can mean a lot of things. So there's when do you not do a lumbar puncture? So when we not do a lumbar puncture, there is the contradictions called fails. So F is for focal neurological deficit like brain abscess. A is for altered sensory due to hydrocephalus. I is for immunocompromise like toxoplasmosis. L is for lesions in CNS, and S is for seizures at CVT. So you should do CVT, corticovenous thrombosis. The fails, focal brain abscess, which is focal neurological deficit. A is altered sensory due to hydrocephalus. I is immunocompromised due to toxoplasmosis gondii, and L is lesions in CNS, and S is seizures due to corticovenous thrombosis. So these are the, you're not supposed to do LP. Now next we have Spectre's favorite neurocystic cell crisis and PMLE. So let's go to PMLE, progressive multifocal leukoencephalopathy, which is PMLE caused by reactivation of JC virus in severely immunocompromised patients. Oh my god, I'm so exhausted. Let's finish. We just have 3 more pages. We just have 3 more pages, and then we're gonna take some 2-minute break or something, just drink water. So progressive multifocal leukoencephalopathy standard didn't take this. And it took, because okay, tuples and R exactly. I told you CNS will take exactly it. Okay, because I already did this before, caused by reactivation of JC virus in severely immunocompromised patients. Pathogens JC virus affects or destroys oligodendrocytes, leading to multifocal demyelination and CNS white matter. Now, clinical features: subacute progressive neurological deficiencies based on lesion location, heavy paralysis, vision defects, cognitive decline, behavior changes, ataxia, and speech disturbance. Diagnosis by MRI brain, multifocal asymmetric white matter lesions without mass effect or contrast enhancement. Diagnosis and treatment by MRI brain. Guys, I'll start in 45 seconds. Diagnosis and treatment: MRI brain, multifocal asymmetric white matter lesions without mass effect or contrast enhancement. I just don't know what I just said. I have no idea what I just said. CSF JC virus PCR confirms diagnosis. Treatment is restored immune function. Now, neurocystic cell crisis, etiology and transmission caused by larval form of T Necillium after ingestion of eggs. Larva encyst in brain and come up or ventricles. Clinical features: most common presentation is seizures. Other features: headache, raised ICP, hydrocephalus, focal neurological deficits. Imaging findings: MRI CT shows ring-enhancing lesions with eccentric dot signs collects. Stages of vesicular, colloidal, granular, nodular, calcified. Treatment is by albendazole and steroids to reduce inflammatory reaction. Anti-epileptics for seizures for 6 months. Surgery, shunt tips, hydrocephalus, or intraventricular glasses. Oh my god, I yapped too much. Get back. We actually have more half left. Exactly half left. But I'm telling you, I won't be just be skimming through RS. RS is a major part here. Look at this. This entire thing is RS. Without you kidding me. There's 30 pages of RS. That's fucking 30 pages of RS. That's like 1/3 of the whole thing, yeah? That's like 1/3 of the whole book. And that's just because the pictures are big. Or as you can see, this is a tiny book. If they did the same as RS, then it's gonna be up to 50 pages. So wherever we okay. So next we have Brown Sequard syndrome because hemisection of spinal cord due to trauma, motor loss, ipsilateral ligament weakness. So you have to remember contralateral loss in pain and temperature. Everything else is ipsilateral, 1 to 2 segments below the site of lesion. Now, syringomyelia. Syringomyelia is fluid-cut syrinx within the central spinal cord due to arteriary one malformation, most common trauma, tumors, or post-meningitis scarring. Classic features: bilateral loss of pain and temperature, cape-like distribution. Motor features: progressive lower motor. So in Darsica, you have ipsilateral ligament loss, whereas in syringomyelia we have element loss. Treatment is by surgical decompression. Then you have conus medullaris syndrome, which is injury to the spinal cord, sacral segment S1 to S5. Hi, Legend Master 62, welcome to the stream. So conus medullaris syndrome, where injury to the sacral segment S1 to S5, motor findings, bilateral symmetric weakness of lower limbs, usually mild with early involvement of sphincters. Now you have saddle anesthesia or sensory loss here. See here is a very specific saddle. Conus medullaris, remember horse. So horse has saddle, so saddle anesthesia. That's literally how they came up with the name. Actually, now why they call saddle is because of how it's affected. You're gonna have loss of sensation of the perianal region with inner thighs. So that's like a saddle-shaped loss of sensory loss. But also easier to remember because conus medullaris sounds like horse. Like it's literally phylum terminal. It's literally horse tail. So easy to remember that way. Now we also have autonomic dysfunction. So remember you're having saddle anesthesia. So what else is along with that saddle? There's your bladder, there's bowel, there's sexual then dysfunction. Then you have urinary retention or incontinence and loss of anal tone. So everything that involves in that saddle is going to be affected. Now, yeah, this is what I said. Cauda equina syndrome. Don't get confused with coda medullaris syndrome. That is tricky. So this is the tricky part. Because I remember conus medullaris as horse, but the true horse is cauda equina. That's where the horse came from. But yeah, very fun. So cauda equina syndrome, this so conus medullaris, we saw S1 to S5, but cauda equina is affected nerve roots below L1, below the conus medullaris. 1 second, yes. One second. Okay, good. We got good. So yeah, where was I? Yeah, cauda equina is below the L1, commonly due to the large disc herniation, tumor abscess. Motor features is asymmetric lower motor neuron weakness, lower limbs with flaccidity, and muscle wasting. So again, it's not saddle, but per se, but your legs are involved. There's going to be lower limb weakness. Oh, there's going to be element weakness with flaccidity. Pretty much how element works. Now, unlike the saddle anesthesia, here the sensory loss is asymmetric, and there's late onset of union cortex, fecal cortex. Okay, so what is horse is not horse. It is about horse. Okay, let's think of it like this. I have a better way of remembering this. Cauda equina is the horse. Cauda medullaris is sitting on the horse. Viola. Easy. It's the saddle on the horse. Conus medullaris syndrome is the saddle on the horse. Cauda equina is the horse. But just don't get confused. Conus medullaris affects below S1 to S5, whereas cauda equina affects from N1. Viola. Okay, last page of sins, multiple sclerosis. This is another Bureau of Higher Science. Multiple sclerosis. I'm not going to reveal who, but they are not yet diagnosed. I mean, they're not seeking. They don't have money for seeking diagnosis. Apparently, poor guy or girl. Who knows? Now, multiple sclerosis, chronic autoimmune mediated demyelination of CNS white tumor. Oh my god, my throat's dying. One more page and I drink water. I'm just exhausted. I'm just out of breath. We were on a rampage. We were on a rampage. Okay, we crossed 1 hour. I think we technically started on a 2-4 or something. So it's fine. It's still exactly 1 hour. Chronic autoimmune mediated demyelination of CNS white matter, T cell and B cell mediated attack on oligodendrocyte and myelin, formation of plaques in periventricular regions, optic nerve, brainstem, spinal cord, resulting in dissemination in time and space of neurological deficits. What we call as Dawson's finger is a hallmark feature where there's going to be periventricular plaques. Now, clinical features, there's going to be relapsing, remitting neurological defects, optic neuritis, painful loss of vision, diplopia, nystagmus, intranuclear ophthalmoplegia, sensory disturbances, limb weakness, spastic. There's going to be something called limit sign. Limit sign is something where electrical shock-like sensation and flexion, bladder dysfunction, fatigue, worsening of symptoms with heat. Sounds like something like an Afro-American word. Like an African word. So Africa, that's very hard to say. They say worsening of symptoms with heat. Okay, investigation, MRI, brain and spine, multiple hyper-intensity lesions and periventricular juxtacortical infraspinal regions, CSF analysis, oligoclonal bands. There's going to be increased IgG index with oligoclonal band. Now, evoke potentials, VP delayed. Diagnostic criteria is called the McDonald's criteria. MRI is the most sensitive investigation. Our treatment is acute relapse IV methylprednisolone, DMT, disease modifying therapy, interferon beta drug of choice. Interferon beta is a drug of choice, which is safe. Natalizumab is used for relapses. Metazorone is used for disability. Baclofen is used for spasticity. Gabapentin is used for neuropathic pain. Anticulin is used for bladder symptoms. So depending on the symptoms, you use the drug. Like interferon beta is the drug of choice. Natalizumab is for relapses. Metazorone for disability. Baclofen for spasticity. Neuropathic pain is gabapentin. Anticulin is used for bladder symptoms. Now we have an entity called neuromyelitis optica, which is due to which is caused by antibodies against aquaporin 4. It's an outline. So what happened? They're present in the astrocyte, so there's going to be astrocyte injury and secondary demyelination. Unlike we saw oligodendrocyte and what's that? Wait, let me see. Oh yeah, and PMLA, progressive myelofibrosis. Leukoencephalopathy due to JC virus, but in neuromyelitis optica, not be confused by that, is due to autoantibodies against APK4. It causing astrocyte injury and affecting optic nerve and the spinal cord. So clinical features: severe optic neuritis, often bilateral, longitudinal extensive transverse myelitis, early bladder involvement, and more disabling attacks in MS. So investigations, you have APP4, IgG positive, MRI spine showing lesion, brain MRI usually normal or not fulfilling MS criteria, CSF often without oligoclonal bands. Treatment: IV steroids with or without plasmapheresis for acute attacks. Long-term relapse prevention with rituximab, azathioprine, mycophenolate. Oh my god, we finished seeing this in an hour. That's an achievement. Okay, guys, we will take a small respiratory medicine. We should be done by 6. We should be done with medicine by 6. And I think night, if we finish medicine, then yeah, we will need to play League or something at night. Oh my god. Let me just. Oh my god, my toadstool. So I'm gonna let the stream for now because and just take this slowly. But I'm sure I'll finish it anyways. But I'm just getting too exhausted. My back hurts from sitting for so long. Anyways, thank you guys so much for lurking and shut up going back to my spicy that is, but yeah. So thank you guys so much for lurking, and I will see you guys tonight. Bye bye.